I am Clément Buléon. I am an anesthesiologist in intensive care attending at the University Hospital of Caen in Normandy, France. I have led our simulation center and the anesthesiology programs for the hospital and the university for the past 11 years. I am also adjunct faculty with the Center for Medical Simulation in Boston, USA. I'm honored by your invitation to share my perspective on simulation as part of COVID-19 pandemic. I do not have any particular conflict of interest to declare related to the presentation. As individuals in society, we have faced unexpected challenges for the past 10 months. Challenges that few predicted but none imagined. Our environment has come hostile and bring threat every day to ourselves and our loved ones. As anesthesiologists, we face those challenges combined with our daily patients and clinical challenges. Adaptation and facing challenges are in anesthesiologist DNA. In addition, though, we can be helped by simulation. A transition time for simulation. Simulation perception and usage has probably changed more in the last 10 months than in the last 10 years. From a meaningful, interactive, pedagogical approach requiring noticeable human and financial resources, it has become, at the same time, a just-in-time training tool, a practical tool to train staff in new techniques, an explorative opportunity to identify risk and threat, an explorative opportunity to identify solutions while avoiding risks, a readiness planning strategy, a way to improve communication. During the next 8 minutes, I will share an overview on how and why simulation should be seen as a particularly useful modern Swiss Army knife serving anesthesia and patient safety in the COVID-19 pandemic we are living through now. Training. A lot of simulation teams have switched to an emergency mode unknown before spring. Just-in-time training and training staff for unusual activities were clear objectives. Thus far, many of our teams have been trained with simulation to perform doffing and donning, intubation and extubation prior to caring for COVID-19 patients. Surgical and ICU team have been trained to pronate and supinate patients as a dedicated team. I'd like to share briefly our hospital experience. We have been fortunate to have time to train staff a few days before the pandemic surge in our area. Almost 1,200 staff were trained in 10 days. We had only 4 contaminations among healthcare providers trained versus 4 times more in those untrained but not allocated to COVID-19 care. Related or not, we like to think there is a link and perhaps the behavior they learn in our simulation translated to their daily life and kept themselves outside their hospital. Risk and strategy. From aerosol modeling to identify contamination, to testing different potential barriers, to minimize the risk for contamination while staying safe and providing efficient patient care, simulation has been actively used to understand and explore potential new procedures by maintaining balance between protecting staff and caring for patient safety. Menzer and his team used in situ simulation in the OR to implement, process, and adapt a COVID-19 airway management strategy among their teams. They applied a plan, do, study, act process that allowed them to be operational in 2 weeks. We had a similar experience in our hospital. We used simulation to develop, test, and train staff on algorithm, checklists, and procedures for a dedicated airway COVID-19 team. In 4 days, we were able to have 11 anesthesiology staff operational while safely and effectively performing our COVID-19 intubation at expert pairs of staff. They become the COVID intubation team on call 24/7 during the first wave. Our training brought safety to these teams of providers as well as the other hospital staff and all the patients. Solution identification. The options of sharing ventilators between two or more patients have been imagined and sometimes used. Once again, simulation has helped in defining safer ways to do this and identify solutions to this challenge. The first and naive approach, connecting patients in parallel, made us quickly understand that with the exception of two perfectly identical ARDS patients, this is impossible to do safely. Herman and his team took this model and advanced it by comparing volume and pressure control ventilation and elucidated pros and cons that favored pressure control ventilation as safer for patients. Simulation allowed this without putting any patient at risk. Readiness. Concerning the readiness that simulation can help us to train for, I'd like to share two examples. One is more specific to COVID, and the second, while it was done for COVID, can be applied in any context. The first example is about using a modified failure modes and effect analysis approach for transferring COVID patient to the OR. Simulation allowed Sevratris and his team to identify multiple hazards and areas for improvement in advance, coupled with feedback to remediate it. Some lessons learned were that communication was impairment with donning, and they needed additional equipment, preparedness, and anticipation of routes they would take to avoid unnecessary exposure of other staff and patients. The second example is about adapting management of intraoperative emergencies to the COVID-19 pandemic precaution. In situ, Dalil Guris and his team used simulation to identify step-by-step barriers and successes and then process a workflow adapted for COVID patients. Throughout this, they moved strategies from work as simulated to work as imagined and eventually improved their work as done. They focused on communication, managing donning and managing the entrance of help in the OR. Finally, they insisted on the pre-anesthetic briefing. As you can see, all of these steps can be applied in any context to improve workflow. Briefing and debriefing culture. The final benefit from simulation that I'd like to share with you is the cultural approach of communication conveyed by simulation. Briefing and debriefing happens occasionally in the OR and in clinical setting, but these are not yet standard procedure as they are in simulation. Simulation. If you have a simulation, you have a briefing and a debriefing. A briefing to orient the participant and the activity to come, and a debriefing afterwards to reflect on the lesson learned and consider how they may be applied going forward. There is a real expertise on briefing and debriefing in simulation that can benefit clinical practice. I'm sure that when you are briefing or debriefing in simulation, you think, it might be interesting to do this in our clinical environment, but it must be time-consuming and unusual. I can't do that. Or should I try? I truly encourage you to give a try. I've done it for almost a year now in the OR, and it is relevant, useful, and the team likes it. A 5-minute morning briefing allows us to share the same mental model for the day, to be aware of our times at risk, to finely tune the team's daily schedule and identify backup resources. At the end of the day, the debriefing helps us to release our cognitive loads, share challenges and successes, along with finding potential solutions. The Center for Medical Simulation described this concept as applied to COVID-19 and created a process with practical tips for briefing and debriefing in clinical setting. This process is called Circle Up. It begins with a brief 5 to 10 minute huddle at the beginning and the end of the day or shift. Everyone in the team is welcome to speak, with the idea to strengthen bonds and promote support among the team, share information and mental model for the day, and get prepared to overcome or analyze challenges. Important information is also transferred to the next team, and any problem identified are brought to a leadership. Finally, the small moments of checking in with each other through the day make the team dynamic evolve, where the team members become more supportive of each other, and by this extension, the patient safety improves. To conclude, I'd like to show you the figure from Bridges on the lesson learned from preparing to face COVID with simulation and how simulation programs may adapt to a new normal. In their case, simulation has benefited from circumstances which allow for demonstrating its potential. In the post-COVID phase, the dotted line, protocol, usability, microsystem testing has returned to the baseline effort of where it was pre-COVID, while simulation activities for education has significantly increased with a gain of visibility and consciousness of its potential. All the facets and opportunities from simulation I briefly described to you have not just appeared. They had pre-existed and are well known to experts in simulation and in safety. As a simulationist and anesthesiologist, what I hope has changed in the past months is the perception of value that simulation brings to hospital managers and leaders. I hope they realize that simulation is a powerful adaptive tool to face challenges and maintain safety. Support from leaders is essential for simulation to be effective. Without it, this work remains limited and isolated. We, anesthesiologists, are aware that crises can occur in our OR and in our daily work. The crisis itself is not our fear when we are prepared and trained to deal with it. It is the unknown and unforeseen crisis that can undermine her ability to keep her patients safe. Though I think it's clear now for you that I make a plea for simulation in anesthesiology for its many benefits, foremost to increase safety for our patients and ourselves. Thank you.